That's fine.
Zoom recording. So hello and welcome to Telehealth. This is episode 7 and I'm your host. I am Sam Fuhrer, and this is a podcast brought to you by American Healthcare Capital. American Healthcare Capital is a mergers and acquisitions firm here in Los Angeles, and we advise healthcare companies on selling their companies. So we usually work with small to mid-sized healthcare companies, everything from couple $100,000 in revenue to up to 100 million. And we represent them on the sale to larger healthcare companies, anything from private equity firms to strategic partners making add-on acquisitions. And this podcast, Telehealth, we speak to professionals in the healthcare industry on basically how life has changed post-COVID-19. And today I have the pleasure to have an amazing guest, Nick Jaworski, who runs his own marketing and consulting firm, and he particularly oversees behavioral healthcare companies. So Nick, you've been in the business for how many years now?
We've been particularly or specifically focused on the behavioral health addiction treatment space for the last 5 years.
You're a veteran in the space. And you, as I understand it, you know everybody. You've got very deep connections in the space and you've been very successful. You've worked with companies up to international companies that are $300 million in revenue to some of the smaller guys, some of the people that we work with. And I mean, just to start off, I want to talk to you a little bit about, Circle Social, your company, and what exact services you guys provide.
Sure, appreciate it. So as you mentioned, we work with, your smaller providers that are doing anywhere between like 2 and 6 million a month, 2 and 6 million a year, all the way up to, we've got some of the largest providers in the country that are doing 300 million a year plus, and everything in between. So it's a wide range. As you mentioned, I tend to know everybody at this point. We're very, very involved in the space, not just from the business end, but also in terms of advocacy. I'm on the board for the Behavioral Health Association of Providers as an advisor. I do board work for some nonprofits in the addiction treatment space, and just really committed to improving the field is a big focus of ours. So as you mentioned, we've got the marketing component that we do, which is just really marketing execution for clients, right? They either don't have a marketing team or they need to outsource that as that's not their core skill set, which is often the case. And then we have the consulting end. So that arm of the business really helps clients mainly in the growth stages. So we've done a lot of turnaround consulting in recent years, but nowadays we're doing a lot more growth consulting, especially as private equity comes in. If they don't really have experience in the behavioral health space, they'll bring us in to help guide the new executive team or maybe to rebuild sections of the business. So that's a pretty brief overview.
So you've really got to probably stay on top of the minutia, because I know things are always changing in terms of laws and licenses that are needed. It requires a serious expertise.
Yeah, we're very involved in the data and the analytics end of things and overall trends analysis, right? So, we've done consulting for like KKR in the behavioral health space, as well as trends analysis we provide to HSBC's behavioral healthcare arm. So we get contacted to provide these nationwide analyses of what's going on, where the industry's heading, and then obviously we give those services to our clients as well, who are looking to, whether it's in a particular state or nationwide, figuring out what their growth strategy needs to be.
Right. I definitely want to get into where the industry's heading. And that's fascinating that you work with companies as large as KKR. They are a client of AHC as well. Just to start off, the topic on everybody's mind is 2020. This has been, quite the year.
Yeah.
It's affected all of our lives, very personally, but I'm just curious, as the industry as a whole, what are some major trends you're seeing, through quarantine, through some of the unrest, anywhere from, general patients' mental health issues to how facilities are operating?
Yeah, I think there's maybe a couple of things I can speak to that are your primary trends. So the first one is really that addiction treatment overall has not been largely affected, especially the larger traditional rehabs. MAT really is the same way, your MAT clinics that are growing everywhere. Not a lot of change in their business. And we have several clients that are full with waiting lists. I'd say the larger clients in the space have maintained or slightly improved their census throughout all of this. So we just really haven't seen a shift in addiction treatment. And there's a couple of reasons. We could go into that later if you want. But then over on the behavioral health side, when we get into either community behavioral or psych behavioral, they really took a hit. And one of the main reasons for that is just the lack of community outreach. They don't really do any direct-to-consumer marketing. So your community behavioral and your psych behavioral space are heavily dependent on the hospitals for referrals, whereas addiction treatment space has been marketing to the general populace for a long time. So that B2C component has really been a benefit to the addiction treatment space. And then there's some differences in consumer behavior as well. Consumers are a little bit more willing to put off most behavioral health needs, whereas addiction, it tends to be a little bit more of a crisis. It generally comes to a head much more clearly for not just the individual, but the family. So I think that has been prompting some of the pushes more into addiction treatment. But that's really kind of the big split that we're seeing is big drop in census around psych behavioral and community behavioral. And then, addiction treatment is fine.
Interesting. So is it that behavioral health companies are kind of missing the mark on some of the modern marketing trends of going direct to consumer? And why do you think that is? I've heard you speak just through some of your talks, I've heard you speak on the difference between the pharmaceutical industry's marketing initiative and how that varies and differentiates from behavioral health.
Yeah.
And I'm just curious, to hear you speak on that a little bit.
Yeah, I mean, I bring that topic up, especially with the psych behavioral and community behavioral. Pharmaceutical companies moved toward direct-to-consumer marketing in the late 90s, right? And as they did that, they saw a shift where they started seeing a huge increase in the number of people taking prescriptions. As much as 30%, sometimes some prescriptions we're seeing a 7 to 9 times increase in the amount of purchases when they combine their boots on the ground, their standard healthcare referral marketing to physicians with this direct-to-consumer advertising. And addiction treatment also figured that out, not necessarily intentionally, but it's just kind of worked out where they figured that out, back in the early 2000s. Behavioral health never caught on, psych behavioral in particular. Psych behavioral is what addiction treatment was, in the early 2000s when it first opened up, especially after the mental health parity laws came into play. So there was just way too much demand and not enough supply. You could hang a shingle and your phone would ring off the hook and your beds would fill up. Psych behavioral was the same, just in a localized area. When you look at your UHS Acadia models, it's the same thing, right? No competition, they didn't have to worry about anything, just opened up, they got all the referrals from all the hospitals. That's changed, that's not the case anymore. Now you've got an abundance of beds in some metropolitan areas. You have a lot of competition moving in. In addiction treatment, there wasn't the capital requirement up front. You could literally just rent out a house and start providing addiction treatment services. Whereas with psych behavioral, you had to, have a $10 to a $20 million upfront investment to build a hospital level facility. So that delayed the amount of time for competition to really come in because those barriers to entry were higher, but it's here now. And that's, I think, what the main difference has been is behavioral health is just waking up to the fact that there is competition in the marketplace and that they have to differentiate, they actually have to reach out into the community, and then they got to figure out who they are and what they do better than the competitors in the same communities.
So they really need to pick up on the branding.
Very much so. I mean, if you talk to your standard psych hospital, they don't really know what they're good at compared to anyone else. They've never built out differentiated programming at all. Or if they did, it was just kind of happenstance. So when you talk to the teams, they don't know what's going on. Tracking and data analytics aren't in place. So if I ask a standard, exec at a psych behavioral facility what their primary patient is coming in with and what they're presenting with, as well as who they are and where they're coming from, most won't be able to tell you. They'll be able to say, hey, well, we get most of our referrals from X hospital, but they won't be able to tell me age, gender, problems they're presenting with or why they're calling. None of that really gets figured out in the mix. And psych behavioral also has a lot of involuntary admissions, right? Sometimes up to 50% of their admissions are involuntary. So those community relationships were more important than the B2C relationships. But again, that's changing because you have competition in the area. So now as a hospital, I have multiple providers I'm going to send to, and I'm going to choose the best one, right? Rather than just choosing the only one that's there.
Right. So I hear you saying two different things. Is that in some sense, there's oversaturation in the market, and that it originally was low barrier of entry, easy for anyone to get into, but now it's highly competitive. And on the other end, it's that it seems like there might be an opportunity if you can differentiate yourself through branding.
Yeah. So you were right in both regards. There is a lot of competition, and when we look at like the addiction treatment space, a lot of providers were just out of network for a long time, and that's changed over the past year or two. But
Right.
when you look at the amount of individuals in the U.S. that are covered by commercial insurance, it's about 60%, right? But the interesting thing is that of that 60%, you only have maybe 1% of them that are actually seeking out addiction treatment services at the end of the day. Most people, and again, it's seeking it out. Yes, there are other people struggling out there, and that's a mistake that private equity makes, and it's a mistake that a lot of providers themselves make, is they think there's this huge untapped market. But the reality is you're not going to convince most people to come in for treatment. It's going to be that small percentage of people that actually seek care. And then you find when they do seek care, they tend not to seek residential. They tend to seek private therapists and family therapists. So when you look at the residential market, it's a small number of a small number of a small number. The market's a lot smaller than a lot of people.
But what you're saying is, a private equity company looking to get into the space sees the numbers like, I don't know, 1 in 20 Americans suffers from addiction.
Right.
And they're like, I don't know, like, wow, there's 5 million Americans who have an addiction issue, but only, X amount of them are getting treatment. If we could tap into this market, then we'll make a killing.
Right.
But the fact of the matter is most people who are going to get treatment are already seeking it.
Mm-hmm. That's absolutely right. And then you've got the local component there as well. So again, private equity has started to figure this out, right? But they didn't really get it, I'd say even 2 years ago, was that people aren't really going to fly for treatment anymore. And that was never a sustainable model. So there was this idea that I could build a center in southern Missouri and get patients from across the U.S. The reality is that your patients are going to come from, depending on your level of care, somewhere from a 30 to 150 mile radius around the facility, right? So you need to be doing local market site selection analysis, not looking at macro trends.
Well, I have a question about that. Would you say there are some hubs, maybe on the high end, that clients will travel to? For example, where I am in Southern California, Malibu, maybe, Austin, or is that a trend of a few years ago that's kind of dying off?
Absolutely. You'll always have a couple providers. There's really two ways. It's specialization, right? Mm-hmm. So if you want to specialize to like a high-end market, providing really luxury care, but that becomes a very strong referral play, right? You have to really get a reputation in certain communities. Maybe it's Hollywood actors, maybe it's doctors and politicians, but that's a very specific model, and it's very hard to build from a relationship and a marketing standpoint. The other direction to go is to niche down, right, and specialize in maybe it's LGBTQ, or maybe it's veterans, or maybe it's pilots. But if you have a very highly specialized program that you can become known for nationally, but then there's only a small volume, so you're really relegated to this small pool of potential patients.
Right.
But you've got a captive market, so both of those can work, and both will definitely fly people for treatment. But the general populace is not going to do that. And the payer pressure is also in the localization director, right? Payers want a community of care. They want you to be able to connect to local providers. They don't want you stranded in Los Angeles, for follow-up services. So the payer pressure is there, the consumer pressure is there. So from a growth business model standpoint, you might have an add-on that's a specialty facility, but your main business or your core business model is still community provision of care.
Right. Just speaking on payers, how would you say, the difference between private pay and in-network companies has evolved over the years? And do you think it's absolutely necessary to be in network if you're getting in the industry, or if you are, providing these types of services?
Yeah, if you want to scale, absolutely. Kind of similar to the last question, is there an opportunity to be a little 30-bed provider that stays out of network? Absolutely, especially like in a high-end community or something like that, right? but it's not a scalable business model. So private equity is not going to want to get into a pure out-of-network provider, right? There wouldn't be opportunity there. The vast majority of people need their in-network benefits. And really, at the end of the day, you've got to figure out how to take Medicaid, because Medicaid is the vast majority of people coming into facilities. I always say, look at your traditional MAT clinic. They literally operate in a 10-mile radius, right? And they see 800 to 1,000 patients a month. Whereas you've got a residential treatment facility that's taking only commercial patients, and they have a hard time filling 50 beds in a 150-mile area. So Medicaid's where the real market is, but obviously different business dynamics with that.
Right, it's more of a volume play if you go in that direction. And just speaking of private equity, I mean, you work with a lot of private equity companies. American Healthcare Capital does as well. Let's talk multiples. Like, let's say I own a small to mid-sized behavioral health company that's doing, $1 million in EBITDA. Granted, there's going to be a lot of, very, factors that play in, but on average, what type of multiple do you think I could sell my business for?
I think it's changing. So 3 to 4 would be your standard these days. I mean, people used to see 8+, right? Some people are getting crazy numbers like 11, not even more than 3 or 4 years ago, but that's not happening anymore. We really saw the downtrend, especially as the payer pressure came in, the push towards in-network, and the realization under private equity that these margins weren't really sustainable and had kind of driven a wave of opportunity that just didn't have any long-term legs on it. I think with COVID, though, we've seen a little bit of a shift because people have realized that all these other industries are struggling, right? Whether you take travel or retail or restaurants, whereas healthcare has traditionally been able to weather your recessions, and addiction treatment in particular is very clearly doing well, right? So I think we're going to be seeing higher multiples again. Not that much though. I still wouldn't see it going past 8, right? Unless you had a really good facility. I think 5 to 6 you might see, but I haven't seen.
That's about ballpark to what we're seeing right now, in the 5 to 6 range. I feel confident telling clients that, granted everything adds up, that we can execute a deal around there. I mean, you bring up a great point that a lot of other industries, like I would not want to be in the live events business or even entertainment and production of some sort.
Yeah.
But healthcare, we haven't seen a slowdown really since quarantine and COVID.
Yeah. I mean, the hospitals got hit real hard. Your outpatient surgical, your pediatricians, your ophthalmology. I mean, those guys got hit hard. But the rate is that it's going to come back. It's going to come back hard, and they'll make up most of their losses as things kind of normalize.
Right. I think out of all the industries, we're going to have a V-shaped recovery, more so than some of the others. But just finishing up here, I want to talk about the title of our podcast, Telehealth, because I know there's been some movements in that, and I don't know if you've been keen to the marketplace of telehealth, but have you seen clinicians treating patients via Zoom calls like this, or engaging in different telemedicine practices? I know.
Yeah, it's a question that all of our clients are asking, and honestly, I think most of them have been looking at it wrong, or at least initially were looking at it wrong. So what you kind of saw, especially among executives, even within the financial community, was this assumption that it was going to go back to the way it was, where I could own a little tiny facility in southern Missouri and treat patients across the entire U.S. I highly, highly doubt that that's going to happen. There's a couple of reasons for it. So we've run marketing numerous times over the past couple of years for pure telehealth plays, way before COVID. So we've had a number of clients with a lot of money try it, and has not been super successful. Now, part of it is these particular clients didn't have great business models, so that was part of the reason that it's failed. But just from a standard marketing data analytics perspective, like we did not see the same level of interest that we see with our brick and mortar campaigns. So we don't see it from the consumer side. And then we have clients, and some very large clients, that have had telehealth programs for a long time. And same thing there, all the patients that call prefer the brick and mortar. they'll go and do telehealth if they have to, right? And like we have one client that we field 150 calls a day just around community behavioral, and everyone wants brick and mortar. They have a special script that they have to run to get them to convert into telehealth because people just don't want to do it. So has that consumer dynamic shifted a little bit at post-COVID? Yeah, maybe, but it's not going to stick around forever, right? The other piece of it is, again, the payers. As a payer, I don't want my patients, members, going into a facility that's completely disconnected from their community, right? I want them to be able to connect into local psychology, into the local healthcare system, into a local PCP, and there's no benefit for me as a payer to promote them to take telehealth services. What you're going to see and what will be effective is telehealth is here to stay, but it's going to be a carry-on service, right? So if you come into my residential program, I can see you continuing on into my IOP, right? That has a lot of high potential, or continuing on into just standard outpatient, lots of high potential there. But what you're not going to see is
it's kind of like a
right. It's going to be connected to the community, and the consumers want that as well. They want to work with someone they know. I'm not going to go, if my local provider offers telehealth services, I'd go with them over someone that's 5 states away. I think the last component that you see with the telehealth piece is that there's an assumption that's cheaper. I'm not sure that I see that. Yes, the only thing that changes is your brick and mortar. You don't have it, but you have higher security requirements. There's issues with more staffing that's needed just to manage the tech and you manage the scheduling. So I don't see a significant cost savings in there. So I don't see that being much of a positive outcome either.
Interesting. So it kind of speaks to your point about it doesn't allow you to scale past. It's still going to be a community program. Yeah. It's just a technological convenience during COVID.
Right. And the thing you see with some of the real large players, I mean, there's been some pretty high valuations with some of these pure telehealth plays, right? But what's the differentiator? Again, it's what we've constantly seen in behavioral health here is you have a couple people come in and they're the sole providers, or there's just very limited competition. So they're able to take up whatever market's there. But the second you have every provider in the country offering telehealth services, which is what's happening now, why would I choose to go with this big national provider, versus my local facility? So I think a lot of those pure telehealth plays are very much overvalued. I don't think they have nearly the long-term potential that some of the firms invested in them think they did. But we'll see where it goes. If they can figure out a way to differentiate or provide a higher quality of services, there might be potential there. But now again, you're competing with everyone and their mom doing the same thing. So how are you going to do it better?
Right. Just a fun fact about telehealth. I learned recently that it was initially developed to treat astronauts. It was developed by NASA.
That's awesome. I did not know that.
Yeah, I learned that in an article this morning. Anyway, Nick, this has been great, very informative. Where can people find you? And I'll put a link in the bio when we share this podcast episode. But just to hear from you, what's the best way to get in touch?
Sure, appreciate it. As most people know, I'm very active on LinkedIn, so that's a great place to connect with me and just kind of follow, even if you want to lurk rather than connect. Otherwise, people can always email me directly. I'm always interested in talking about behavioral health, addiction treatment, and what's going on. Even if you just want some free advice, I'm usually willing to give a bit of it. So email address is nick, N-I-C-K, @circlesocialinc.com.
Awesome. I'll put that in the bio. This has been episode 7 of Telehealth, brought to you by Sam Fuhrer at American Healthcare Capital. I oversee mergers and acquisitions in behavioral health. Nick Jaworski, thank you so much for coming on. I will touch base with you soon.
Thanks.